Thank you for the introduction and this short-term invitation to give a presentation. And I'm working at the Biomedical Primate Research Center, which is one of the largest primate centers of Europe. And here you can see a picture of a bird view of the center, and we're housing different species. The marmoset monkey, and that's where the focus of my presentation is on, but also cynomolgus, or what we call long-tail macaques, and rhesus macaques. And they are all living in these round areas in groups. And the presentation will be about ketamine as a treatment for emotional memory, with a special focus on PTSD. And people are diagnosed with PTSD. Oh, yes. When a person has experienced, witnessed, or been confronted with an event that involves actual or threatened death or serious injury, or a threat to physical integrity of oneself or others. And that results in avoidance behavior, but also in hyperarousal symptoms like cognitive problems, concentration, difficulties with sleep, and re-experience of symptoms, which can be very useful because that helps you to avoid the same situation in the future. But sometimes these memories, these fearful memories, are retained very well, that it also influences your daily life. And this will be also the focus of this presentation. How can we treat these fearful memories? There are already some treatments for PTSD, like cognitive behavioral therapy, group therapy, and exposure therapy. And they are all focused on the trauma memory, but in general, it's very time consuming. So it would be much nicer if you can help these therapies together with a pharmaceutical approach. And the current medications, the drugs therapies, what are already available, they help to ease symptoms of depression, anxiety, or can help also with sleep. But there's still no cure for PTSD. So the treatment, what I already mentioned, will be on targeting the emotional memory. And there are different time points where you can do that. Of course, the consolidation, to block the consolidation and the first exposure, but that is from practical point of view very difficult to do because you don't know when you will be exposed to a trauma. But for research, you can examine this type of blocking consolidation. But more for the application for the patients, it's better to focus on the reconsolidation or the re-exposure to block the reconsolidation or facilitate the extinction of this trauma. And for both, you need the NMDA receptor. If you can talk about reconsolidation or extinction, that depends also on the duration of the re-exposure. And short exposure in generally leads to a reconsolidation, and longer or repeated exposure, re-exposure, leads to an extinction. So if you want to facilitate it, you need an NMDA agonist. But if you want to inhibit it or block it, then you need an antagonist. And ketamine, as you all know, is an NMDA antagonist. So I have visualized this emotional memory here with a kind of office with a filling cabinet of memories in the brain and a desk where you can work on. So in every box of this filling cabinet represents a certain memory. There can be family, school, or sports, but also trauma. So when there comes a new exposure to a certain memory, a trauma memory point, this trauma 2, then you need from the box, then the documented files belonging to trauma comes out. And at that moment, the memory becomes liable. And then, but to consolidate it again, to reconsolidate it, you need a new processing. And that's the same procedure as for the first consolidation. And you have to fix this memory to the file, what belongs to the memory, what was already stored. And to do that, you need an AMPA or an NMDA receptor to fix it to that document. And it's here with the stapler. So it's fixated and then it's stored again in the files of trauma. So if you would like to prevent this storage, you have to take care that the AMPA or the NMDA receptor are not doing what they have to do. And that's by blocking. What is the special role of these receptors? Here you can see an overview from a postsynaptic site of a neuron with NMDA and AMPA receptors. And the AMPA receptors, they mediate fast ongoing synaptic transmission. So when there's glutamate binding, then it's opened for sodium and sodium ions. They enter the neuron, and that will result in a local depolarization. And this results in the release of the magnesium, what was covering the NMDA receptor, after which the calcium can enter the neuron. And this upregulation of this calcium in the neuron affects its metabolism, and that will result in an upregulation of the AMPA receptors. And that triggers these changes in synaptic strength. So the neuron will respond more rapidly and strongly to glutamates. And this upregulation of the AMPA receptor induces also long-term potentiation, which has been associated with consolidation of emotional memories. And there was a question about propranolol. Would that also do the same as ketamine? And you see both play a role in this facilitating of this memory. So only propranolol binds directly to the AMPA receptor. So with the ketamine, you draw a line over here. I don't know if you can see also my mouse arrow. I hope so.
Yes, we can.
Yeah. So then you draw the line over here and prevent this stage. But if you block the AMPA receptor, you can already draw the line over here. So there's actually also no calcium influx before. So that makes not really any difference if you choose for an AMPA or an NMDA receptor, but it can result in other kind of side effects. So you have to be aware that's not the same effect, but it can lead to the same results. So to test it, we need a model. And yeah, I'm working at a primate center, so we are working with primates, and we choose also to work with non-human primates because from translational point of view, they are closer to humans than rodents. But in rodents, you can also learn a lot about the mechanistic aspects for what I told about this, the previous slides, about how it's working on receptor level. But the marmoset monkey, that's a very good model because it's a small animal and it's easy to handle. When you have the large rhesus monkey, it's very difficult to do any behavioral studies. These monkeys, they are only 300 to 500 grams in body weight, so that's really small. It's a New World primate, and originally they live in Brazil, but we have our own breeding facilities. And they live in families with a female, male, and their offsprings, and also the offsprings, they help with the brothers and sisters, and they get twins twice a year. And when we put them in the study, we take care that the brothers or sisters stay together. Because it's important when you do research towards to stress models, that you should not already induce stress just by keeping the animals. There are several ways how you can induce stress in these monkeys. Of course, you have the social stress, and these are very social animals, so that's a very strong stress induction, or physical stress. And Social stress can be induced by naturally, like instability of housing, change of cage, and you can see that can have a huge impact of these animals, or social defeat that's in most cases induced because there is no social, no intruder when they are in a cage. So you have to introduce them. Or early life stress, like maternal separation, or the social isolation. And I have an example of the social isolation here when you follow a monkey before, when they're in the social situation, or during 2 weeks of isolation and after resocialization, when they are placed back in the group. Here you can see the effect on cortisol levels during the isolation, but that recovers after resocialization. But when you look at mood effects on behavior, like staying in the back of the cage, that increased during the isolation, what you expect, but after resocialization, it's not improving anymore. So that something has changed already due to those 2 weeks of isolation. And that means that these monkeys are very sensitive for stress induction. And you see also inadequate grooming goes up, but also signs of depression. And we measure that by huddle position, that they put their heads lower than the shoulders, what you can see a little bit over here. And normally they are more stretched. And this is also a position what you see when they are more stressed, and also the movement left to right. I cannot show you, but there are different types of expression what you can measure. Also that they are rearing, but also with the face with the ear puffs going backwards. So there are all kinds of expressions of body postures what we can measure, and we can score them. And the drawback of this social isolation is you don't know when the stress was induced, when it started. It's more a kind of chronic stress paradigm. And with post-traumatic stress, you know exactly when the trauma was. So this is not very useful for testing the effects for post-traumatic stress, but maybe for another kind of study, but not for that. And therefore, the physical stress, the light goes off, is a better approach that makes use of an electric foot shock, like a classic conditional procedure. So it relates an aversive stimulus to an environmental factor, and the environmental factor can be a light, a sound, or the apparatus where the animal is in at that moment. So there's a shock context within situational memories. And what's so nice from this approach is that you know exactly the time of the stress exposure, and you also know exactly the time of the treatments. So this makes it possible to treat during the consolidation, that's the trauma, the first exposure, but also during the reconsolidation or during the extinction. And that's why we use this approach with electric foot shock. And it sounds very nasty, but it's comparable what you have also when you have cows outside and you have those wires, and when you touch it, it's not nice, but it's so short. It's only a fraction of milliseconds. And it's more that the monkey does not know what's going on. And we make use of the passive avoidance that consists of 2 compartments. It's an illuminated compartment and a dark compartment. And the monkey can change from one compartment to the other. But when the monkey goes in the dark compartment, there's a sliding door in between. The door will close for 15 minutes. And the monkey doesn't know if it takes 15 minutes or a whole day. So we know it's 15 minutes, and that's already a long period. And within that 15 minutes, on random time points, a very short foot shock will be given. It's not hurting, but the monkey does not know what's going on. And that makes this kind of trauma. So and when we look 1 week later, we place them again in it, in the same situation, but then we keep the door open and we can measure how long it takes before the monkey goes in that dark compartment. So here you can see the door opens, goes in the dark compartment, the door closed, stay closed for 15 minutes, and random food shocks are given. 1 week later, we place them in the same shock context, so with the situational memory, and now the door stays open. And we only measure how long does it take before the monkey would enter the compartment. And here you can see normally the first week, they enter it within few seconds. But after a week, because they remember that the dark compartment is a dangerous compartment, it take them something like 6 minutes, I mean, not seconds, minutes. So there's a huge increase in delay of the time to enter the dark compartment. But when we look on other parameters like cortisol, during the first consolidation, you see an increase of the cortisol, and that was not found during the reconsolidation. That means it's the re-exposure is only the memory of this exposure, what was 1 week before, but it has not the stress effects, it was only the emotional memory. You see it also when you look at the REM sleep. Normally after a trauma, the night after trauma, the REM sleep goes down. It's the percentage of REM sleep. But that was not the case during the second week. And also when we look at the heartbeat, it goes up, but not during the second exposure week. That means the re-exposure is not a trauma by itself, it's only there to remember the trauma. What we can see over here. So if we would like to treat that, we have to take care that the NMDA receptor is not working anymore. So if we would like to prevent this memory, and if we do that, so the NMDA receptor is not doing what it should do, then the memory cannot be fixated on that document, on that file of this trauma, and it will be stored without that extra exposure, and it will be stored somewhere else. So it's not forgotten, but it's just stored in another box, maybe of a holiday or sports or whatever. So it has not the same load as it should have been when it was stored in the trauma box. Let's see what. So we did that. Here you can see again in this situation. So the monkey goes in, the same passive avoidance. So the NMDA receptor play a role already in this consolidation, but also during the re-exposure, then the emotional memory becomes liable, it's on the desk, and needs a new processing to consolidate. But if we treat the monkey with saline or with ketamine, 0.5 milligram per kilogram, and that's a very low dose. Normally for sedation, we use 25 milligram per kilogram. So that's much higher. So this very low dose of ketamine is already enough to block the NMDA receptor. And I think it's important to dose, because when you use a higher dose, you can have a complete different effect than a low dose. And that's also what you see in literature, that's you see different results in different studies. And when you look what's different, it's the timing. When are you giving it 1 week before, or 1 hour before, or after the reconsolidation? And we give this injection immediately before the reconsolidation, before we put them in. And the optimum of ketamine is about after 5 or 10 minutes already. so that works very quickly. But the duration of this test is 10 minutes. That means that the ketamine is active immediately after the exposure, the re-exposure. And I think that's the good timing, because if you do it later, maybe then you block the extinction. And that's what I show you before, that you have an extinction when it takes, the duration is longer or more repeated. If you put the animal just in this situation, it can be that you how do you call it, activate the extinction. And therefore the timing is so secure, and we still don't know. We test just this timing, which was a very good one. We found out later, but some people, they do it on a different time, and that's why it's so difficult to draw any conclusions from studies, what's already done with these compounds. And yeah, what I can say now is I think that the timing and the dose, that all depends on what you are influencing, the extinction or the reconsolidation. But we did it immediately before the, and not that they were sleeping during, of course not. That can be when the dose is too high, then nothing comes in. But the optimum was directly, of ketamine was directly after the exposure. And when we look 1 week later, what we see is that the saline control animals, they still remember, they have had the first exposure and the re-exposure, and they know that's a dangerous compartment, a dark one, so they did not enter it anymore. Whereas the animals who received ketamine, they were still going during the reconsolidation, just after 6 minutes, but just looking around in the box, not completely going in. But 1 week later after ketamine, they were still entering the box as if nothing happened over there. And here you can see the time. So during the first week, it was just a very short period that they enter it, because they are curious and they are looking what's in that other box. But 1 week later, they remember that's not a good one. And another week later, the saline controls, they know it's really a bad decision to go to the dark compartment. Whereas the ketamine treated animals, they were slightly already recovering to the normal latency time. Also, when we look to the stress-related signs, it was not significant, but when you look at the controls, you see an increase over time from stress-related signs from baseline to after the follow-up trial, and with ketamine it was less. So it's not only that the memory was affected in a positive way with ketamine, but also they were showing less stress-related signs. And what was very remarkable, when we look at the brain, we found that the neurogenese was declined with the DCX, double corting cells, that is a staining for maturation of newborn cells, that went really down almost to 0. But also, if we look at the BRDU, and this is a marker that is incorporated in the DNA, you inject that before, and you can follow that afterwards in the cells on the histological staining. And that's more for the survival of newborn cells, but also that goes down. And of course, I don't think that ketamine is leading to this reduction for a longer time. So maybe if we had looked 1 week later, we could not find this effect. So the timing for the histology was, I think, a very good chosen but that's afterwards. You don't know before what you will find. So we didn't expect this, but it is also an indication that ketamine is not only acting on the NMDA receptor, but probably also affecting the neurogenesis, which makes that there are less synaptic connections for storage of new memory. So that can also be one of the reasons why ketamine is so effective in this targeting of the emotional memory. I think I go too fast, but so the conclusions is that the passive avoidance paradigm, that's what I show with the inescapable food shock, that activates indeed the formation of fearful memory. They remember very well not to go in it. And you can see that it is also trauma related because cortisol goes up, it reduces the REM sleep, and also the heart rate goes up. And that was only during the exposure and not during the re-experience or the re-exposure. And ketamine treatments upon the reactivation during reconsolidation of fearful memory mitigates the expression of fear memory, what we could see, that, but it also influences the neurogenesis. So that via the decrease in the proliferation or a reduced survival of earlier born neurons in the marmoset hippocampus. We look at the hippocampus for this change. And that can also be an explanation. So it, and of course, we cannot tell exactly what's going on, but it is a start for further studies to look what is the best timing. And this looks like it's a very good timing for to treat the reconsolidation. And maybe also the proper timing for the effect on neurogenesis. But we have never looked at ketamine by itself after 1 week of injection, what it did with neurogenesis. So we don't know if this is related to a combination with the trauma and ketamine or just by ketamine by itself. So I want to keep it here. And so now we have plenty of time for discussion, I guess. Mm-hmm.
That's really terrific. Thank you so much. Really nice and clear and really helpful to as a start for this. So we've got some questions here. First question: how did you give ketamine, and what was over what period? So you need to know that clinicians give it over a 40-minute intravenous period. Oh, yeah. So how did you do that?
It was an intramuscular injection in the leg, and yeah, that takes 1 minute. It's so it was, but it's not an intravenous injection, but intramuscular, so it takes a little bit longer before it's in the bloodstream. But
okay, okay, how does your data on neurogenesis fit with other work showing an effect of ketamine on synaptic plasticity? In other words, increased synaptogenesis. So I think most of us will be a bit surprised to see that there was a reduction in new cell neurogenesis.
Yeah, that was also, I expected also the other way around. So we were really very surprised when we found this, because we all were thinking, oh, there will be a reaction on it, so it will increase, but that was not the case. And maybe it's also the timing. It was the timing, the day after we collected the brains, the day after the 3rd week test. So when we could really see this difference between the saline and the ketamine treated animals. So it can be that maybe 1 week later it will be different, but I don't think that the memory would, the effect on memory will be go back to as it was for the saline. I think that was already, because if the monkeys already notice it's not a problem anymore, because that's with the re-exposure, why should it's and then you could, so some people say, oh, maybe it's an increased extinction. And that was also in the discussion, but I don't think it's based on extinction, because for extinction you need a longer time of the re-exposure or repeated exposure, and that's what other people find in other studies. When they give it before, you can inhibit extinction, and yeah, that's difficult to explain. What was the question? Was the first question, because now oh yeah, that was about the histology. Yeah, it's very strange, the histology, what we found, but it can be a very nice finding that this is happening. And what we also would like to know, what is happening with the BDRN. Yeah, because that can be measured in blood. We tried to do that in the marmoset, but all the assays we could find, they were for human beings and they were not working in the marmoset monkey. That was a pity, because that would be really nice to know what's happening on that level. But this is what we found. And it's really strange, because we also expected an increase and not a decrease of the neurogenesis. But if this, and this is what we found, it can also help to find an explanation what's going on.
Okay, thank you. Did you see evidence of persistent general stress behaviours in the animals who received the foot shock once they were back in their cages and families after the first foot shock exposure? And
Yeah.
if so, did this change after ketamine?
The first exposure was for all the animals the same, and indeed they were not very relaxed afterwards. The heart rates, we measured the heart rate afterwards in the evening, and it was still up. So what I showed, this increase of heart rate, was in the evening, whereas around noon we exposed the animals. So they were not really relaxed during the daytime. And then we measured also during the night the sleep, and we could see that the REM sleep went down in all animals. So it has a long effect during the whole day after the trauma.
And I think that the question actually is what happened after they then had the ketamine.
Oh,
so what was their social behavior like after the ketamine, after they'd gone back to the cages after
yeah.
the
No, the ketamine animals were much more relaxed than after. Yeah, it is a very low dose, so they had no really effect of the ketamine by itself, because if you go in a higher dose, then they will be more kind of sedated. But they were just acting really normal, much more normal. And that's also what we could see because we observed them every day, every morning. And we did it also on the day of exposure, also in the afternoon. And we could not see any changes compared to the controls. They were much more stressed than the ketamine animals.
Thank you. Can I ask you?
That means that there was already a direct effect after it.
Yeah. So the clinicians here won't be very surprised by that. That's the sort of what one would expect, I suppose. Have you considered testing higher doses, and any ideas of what dose would produce differential effects in your paradigms? So you talked about them being sedated. How much higher would they have to be sedated?
So when you sedate them, we give them 25 milligram per kilogram, and now it was 0.5. So that's a huge difference.
So their behavior when they'd had 0.5 looked normal. So when we give humans, if we give humans a, effectively an intramuscular dose of 0.5 milligrams per kilogram, their behavior would change. But you're saying that in the
they were with ketamine, it was not actually precisely the same as what you see with the controls, but not every monkey. So that was also depending on the individual. But there was one monkey, but we had one monkey, we make a mistake. We had, instead of 0.5, we give that animal a little bit higher dose. There was 5, 10 times higher. And we could see there was kind of sleep, how do you call that? Wiggling around sometimes, and then we're standing up. So it's, if you go a little bit higher, then you can see some motor coordination problems.
Just out of interest, was that animal in the data, included in the data?
Yeah, because we included in, because it did not change, all the parameters we tested were in the same line. It was no outliner, and that's why we keep it in. So we had a range between the 0.5 and the 5. That one animal, that's only one animal, but we could not see any difference. So maybe that 0.5 was as low as you can go, but if you go a little bit higher, it did not make any difference. So maybe that's important to mention. I put it in the paper too, that we make a mistake with one animal, but it was in the same line, was no difference, was no outliner from all the results.